Hello there. This is Andrew Kolsky with Stop My OCD. And today I have the benefit of having two of the interns with my practice to share their experiences, specifically working with our OCD support group. We've got Lane Smith and we've got Josh Torres. And I'm going to give them an opportunity to introduce themselves, tell us what school you're with and a little bit about yourself. And then I'll have some questions for you so that other people who are considering doing an internship or residency, any sort of counseling related OCD, can benefit from your experience. So why don't we start with Lane? Lane, can you introduce yourself?
Hi, my name is Lane Smith. I am in the home stretch of my clinical mental health counseling degree at Marymount University.
Thanks, Lane. And Josh.
So my name is Joshua Torres. I go to New York University. I was born in Bronx, New York, moved to Ting, New Jersey, attended Concordia College for my bachelor's, and moved to Virginia. So here I am.
Excellent, excellent. Well, thank you both for joining us today and being willing to share your thoughts and information. You know, one of the things that I know you've heard me say during your internship, and one of the things that I say a lot when I'm giving lectures about OCD, and it's true for myself as well, is that when I was in school for counseling, I really didn't get much information at all in my program about OCD. And I realized there's a lot of different things that a school needs to put into their curriculum to be able to get you through before you graduate. But what happened for me is that led to me starting off my internship and my residency. And looking back, I had some clients who now I can see had OCD, and I just wasn't aware of it at the time. And I'm curious for each of you, what has your experience been from the educational side? Have your schools had an opportunity to spend much time on OCD, or what is it like for you? Lane, what about you?
Now that I've worked with you a bit, what we covered doesn't really seem quite enough. We covered OCD in part of a single class, and we spent about 50 minutes on it, and not just OCD, but related disorders such as, body dysmorphic disorder, hoarding, trichotillomania, excoriation. It all just kind of got lumped in. And it wasn't until I started working with you that I realized just how prevalent OCD is, 1 in 40, 1 in 40. And also that there is a range of presenting concerns. And that was really, really kind of a shock to me. And all the different kinds of OCD too. And each of them has their own personality, it seems like. So yeah, not much.
Yeah, well, thanks for sharing. And this is not a cut down of schools by any means. It's just the reality that there's so many things that the programs have to teach, and they can't possibly get into, strict detail about any of them. What about you, Josh? You're at a different school, so what about your experience?
My school in New York, I don't think they offer an OCD class for my school program. Maybe it'll be a good idea after, just working with you for at least a year. And they offer so many classes, but it's pretty rare to see like a class specifically about OCD.
Yeah, and that's pretty much what I hear from everybody. I've never heard any student who had, more than just sort of a passing, discussion about OCD. And so that's why I do these videos and things to help educate people about what it really is and what it's like. So, each of you has helped me with the OCD support group that we run. This time I'll start with Josh. What got you interested in being involved with the support group in the first place?
Well, just overall, I like working in a group setting. So it's kind of like an opportunity for me just to like gain some like group counseling or just like facilitating a group setting. So I really appreciate that kind of like opportunity. So I guess that's just overall just me. Like I enjoy just working in the group.
Yeah, and I can tell you do. I watched you grow from doing your very first group to now just being an expert facilitator and running it without any problems. So, you know, and that's part of an internship, is getting the exposure to those things and learning about it. So that's one big gold star for you. What about you, Lane?
You know, I've really appreciated being a part of the group, kind of being a wallflower, watching Josh and you work. It's been a wonderful experience. The sheer diversity of people and uh, places that they come from in their life, it's kind of amazing. Just about anyone can have OCD, and for any of a number of reasons, some people seem like it's always been in their lives, and sometimes it just takes a traumatic event or a realization to really tip them over the edge and make it a problem.
Mhm.
And I've really enjoyed hearing their stories, really putting a name and a face to a disorder. And it looks very different than what you read about. It really does. It seems it's quiet. People don't share unless, you know, they're given the forum to talk about what they're experiencing, and the suffering is discernible once they do. Yeah.
Yeah. I mean, how many of the people that come to the support group have said, you know, this is my first time reaching out. I haven't received treatment before. I didn't know that anybody else had this. I mean, that's kind of a common thing that we hear. So along those lines, since you both have had the opportunity to see sort of a variety of different people, we'll start with Lane on this one. Is there any particular case or any particular issue that stood out to you that was interesting or that you didn't expect to hear when you were talking about, you know, listening to people talk about OCD?
There wasn't really just one, because there's never just one. There's always a constellation of ones. It's this and also that and that and that. Like the way that some of the people felt pretty lonely, like they couldn't really talk about it because of the communities in which they were a part. Another thing that came up that was really kind of heartbreaking for me was just when someone would call in from being really close to a trigger that they had experienced, and they were just like white knuckling it. They were needing that support. They know that they needed to do this activity or be in, you know, a close proximity to that trigger for whatever reason, but they were still going through it. And they're at like an 8 or a 9 out of 10 on what it was doing to them, the processing was, and just being allowed to share and be a part of that experience was, I mean, it was nerve-wracking, but it was also very powerful. And I think those were the really big takeaways that I've had so far.
Great. And Josh, how about you? I know you've been doing the sessions a little bit longer than Lane has, so you've seen even more people in diverse situations. What would you say was sort of one of the biggest things that you learned?
I guess for those who are not aware, like people with OCD and people without OCD attend the support group. Just just learn a little more about like OCD and gaining the resources and listening to, you know, just different stories and different perspectives. But what stood out to me is like how it can affect the relationship between the caretaker and a person with OCD. And it's just a lot of work. And coming from a caretaker who wants to take care the person with an OCD, whether it's a son, a daughter, a friend, or just somebody, but just know like their way of trying to help out is to give into that OCD, and it can really like affect that persons with OCD. And I believe the support group gives a space for just anyone to say like, I did bad, I made a mistake, and it's just enough for them like to feel reassured knowing that like they're not the only one going through this.
Yeah, we do have a lot of people in that situation who don't have the OCD themselves, but they are a wife, husband, mother, father, friend, caretaker of someone. And we've had the opportunity during session to talk about the process, I call it sort of accommodant, because we don't want people to accommodate. And we have another video where I go into that in more detail and explain how to do it. But yeah, it's really hard for someone who's a caretaker to not want to accommodate the person and make them feel less anxious. The problem is that feeds right into the OCD. So so we do talk about that quite a bit. One last question for each of you, and we'll start with Josh on this one. So if you were to have to give some feedback or advice to someone who's either a student or a counselor who's considering, working with OCD types of patients, what suggestions would you have? Would you say stay away from it? Would you say it's a great area to go into, or what should they think about? Give them some advice so that they know where to start.
I guess even for myself, coming in blindly, this open world of, just doing counseling stuff, just take the case, but also be aware, does your supervisor has any experience working with people with OCD? That's major key, because not many, well, some counselors don't have that kind of experience. If they don't, this is where, as an intern, as a licensed professional counselor, need to do the research on OCD. There are a bunch of resources online. There's a bunch of webinars. You can go on stopmyocd.com. Maybe you go on YouTube. This is the moment where you really need to take this seriously, do your research so you can do effective therapy. And some ways of using, let's say, person-centered theory, it may not be very effective with a person with OCD. So the proper approach would be CBT. So that's something like new upcoming interns need to be aware of, is what kind of approach would be the most effective with the person with OCD.
Yeah, that's a really good point, because one of the other big things that I know we talk about a lot is that anxiety in general is sort of a big thing that any counselor is going to see in many of their patients. The challenge with OCD is that the way that we treat anxiety, if somebody had generalized anxiety, is quite different from what we might do with OCD. And so oftentimes, I'll have clients call up to inquire about treatment, and they'll tell me that they've maybe worked with someone else for a couple of years trying to do talk therapy, and they just haven't made much progress. And it's generally what I find out is, they've been working under the assumption that they had generalized anxiety. And when we get into it a little bit more, we find out that it's actually OCD. And then we can kind of tweak the approach. And the thing that drew me to OCD was it was amazing how someone can come in full of distress and really at the end of their rope, not knowing what else to do. And unlike so many other disorders, in a relatively short period of time, we were able to take them from total distress down to like, yeah, I'm okay now. And to see that, to me, is really rewarding. And that's one of the main reasons that I do the OCD work. So Lane, what about you? Any advice for people considering treating OCD?
I think what I hadn't really considered about exposure therapy, which sometimes you use in your treatments, is that it really involves making the client feel uncomfortable and staying uncomfortable and resisting the urge to make themselves not uncomfortable, because that urge often takes them to the obsessive fulfillment of their compulsions. And realizing that, I was like, am I willing to do that? Am I willing to do that to help someone with OCD? And I think the answer is yes, to help a client, but it takes me to a place that it's difficult, And so having to wrap my mind around that, making someone uncomfortable, which is the opposite of what we're supposed to ultimately allow them to be more comfortable in life, is something that, as a counselor that you're considering working with this population, you might want to consider.
Yeah, and I think that is one of the main things that causes some people to not want to do it, because it's hard to put yourself in a position where you're intentionally, raising someone's distress level temporarily, but as part of the treatment, it's a necessary evil. And some people just don't want to, they don't feel comfortable doing that, and that's perfectly fine. And that's why we have so many different types of counselors out there. And there's other people that specialize in other areas that I would not be comfortable with, because I don't feel as competent there. But I just, like I said, I personally enjoy the fact that you can have someone come in with such distress and help them lower it. You can see and feel the success, and that's something that I like. So before we close out, I'll just ask for either one of you, any other things, thoughts that you might have that you want to share with our audience before I close it out? No?
I have a question. I have a question for you, if that's okay.
Sure.
I was talking about this with several classmates the other day. It seems like it's become pretty commonplace for individuals to claim OCD, that they have OCD, perhaps jokingly, to explain, their need to be particular or a tendency to obsess or seek perfection in certain regards. Does OCD symptomology, in your mind, exist on a spectrum? Is there a clear dividing line between what is problematic and what is not?
It's a very good question. And the answer is not as clear as we would like it to be. And what I mean by that is, so first thing that I do with any new client is I try and diagnose what's really going on here. Is this someone who has generalized anxiety? Is it someone who has OCD? It could be someone with, obsessive compulsive personality disorder, which is related but different. It could be someone even with, on the autism spectrum. There's a lot of similarities that can be easily confused. So there's a lot of background questioning that I do, assessments that I do, in order to try and figure that out. And then you'll have, what I often tell my patients is, and this is not based on a scientific study, but it's my experience, that I typically see two types of patients. One is the person who will say, oh, I've always had these types of obsessive thoughts ever since I was a kid, and they come and they go, and they're different ones. And then the other type is the person who did not have that history, but something happened, often some kind of a traumatic thing. And as a result of that, they started to develop these obsessive thoughts. And they can be at varying degrees. So some people might have, a single thing that is causing them obsessive thoughts. Other people can have multiple things going on. Often, if you see multiple things, you tend to find a common denominator in there, but you have to kind of get to it. So it really is the type of practice that requires you to be very analytical, very open-minded, and consider a lot of different things. And then, another thing that I often find pretty regularly is you will have someone who does indeed have OCD, but they also have some trauma that they haven't dealt with yet, or something else going on. And in my experience, it's always important to treat those other things first before you treat the OCD. Because with the OCD, remember, we're going to be raising their distress, and it's hard for them to deal with that when they got other unresolved trauma and things going on. So it's a great question, but like I said, it's sort of a murky answer because it depends. And that's probably the lawyer in me too. Our perfect answer is, well, it depends. So, but thanks for the question. Excellent.
Thank you.
All right. Well, I want to thank both of you for taking the time to share your experiences, and hopefully as other interns and other therapists get a chance to see this and hear about your experiences, they'll be able to make a better informed decision of whether OCD treatment is something that they're interested in, or maybe they want to stay far away from. Either one is okay. But if you are watching this video and you yourself or you know someone who might benefit from an OCD support group, you can simply go to stopmyocd.com and right there sign up for the support group. It's free. There's never been a charge and there never will be a charge for it. And our goal is to help people support each other. So thank you for watching the video, and thank you to both of you for joining us this evening.
Thank you.